Good morning, everyone. This is February 6th, 2024. We are in Orlando, Florida. Welcome to the Orlando GI Journal Club for February. Our first study is a randomized trial published in The Lancet by Almanza et al. Shyam and I were also a part of this randomized trial. A combination of rectally administered indomethacin and placement of prophylactic pancreatic stenting is recommended to prevent pancreatitis after ERCP in high-risk patients. The use of indomethacin alone may eliminate or substantially reduce the need for pancreatic stent placement. And the aim of this randomized trial was to compare the rate of post-ERCP pancreatitis in patients receiving rectal indomethacin alone versus combination of indomethacin with prophylactic pancreatic stent placement. This was a non-inferiority randomized trial involving 20 centers across the United States and Canada. The non-inferiority margin was set to 5%. The patients, treating clinicians, and outcome assessors were blinded to the study group assignment. The endoscopist performing the ERCP was not blinded. Patients who were at high risk of post-ERCP pancreatitis was enrolled, so inclusion criteria included meeting at least one major criteria, which is history of post-ERCP pancreatitis, difficult cannulation, the need for pre-cut sphincterotomy, pancreatic sphincterotomy, balloon dilation of an intact biliary sphincter, and clinical suspicion for SOD. Or if you met two or more minor criteria, you were also eligible for enrollment, which was females less than 50 years of age, history of recurrent acute pancreatitis, and at least 3 pancreatic duct injections during the RCP. The randomization was in a 1-to-1 ratio to either rectal indomethacin alone or combination of indomethacin with prophylactic pancreatic stent. The primary outcome measure was the rate of post-ERCP pancreatitis. 975 patients were assigned to indomethacin alone. 975 were assigned to indomethacin with stent. And if you look at the demographics, the majority were female, 61%, versus 39% or so for men. 25% in the indomethacin with stent group had clinical suspicion for or an actual known SOD. 42% in patients with indomethacin alone were suspected of or known to have SOD. History of post-ERCP pancreatitis was present in 2.5% of indomethacin with stent group versus 3.7% of indomethacin alone group. Difficult cannulation was encountered in 84% of patients in the indomethacin with stent group and 82% in patients assigned to indomethacin alone. Brain involvement was in 56% of cases with indomethacin with stent and 56.9% of indomethacin alone group. The total lactated ring-as fluid received during the peri-procedural period was just over 1 liter for both groups. In those in whom a pancreatic stent was placed, the majority of the stent diameter used was 5 French, and then followed by 4 French, and then greater than 5 French or 3 French, encompassing 4.6% of the indomethacin with stent group. If you look at the primary outcome measure of the incidence of post-ERCP acute pancreatitis, the rate of ERCP pancreatitis was at 11.3% in the indomethacin with stent group, 14.9% in the indomethacin alone group, with risk difference of 3.6%, with a 95% confidence interval of 0.6 to 6.6%, and this is on the intention to treat analysis. If you look at the next slide really quickly, so from these study results, you can deduce that indomethacin alone is inferior to the combination of indomethacin with prophylactic stent with p-value of 0.011. This is because the upper limit of the 95% confidence interval exceeds the non-inferiority margin of 5% at 6.6%, and the lower limit of the 95% confidence interval is greater than 0 at 0.6%. If you look at the secondary and safety outcome measures, the incidence of moderate to severe post-ERCP pancreatitis was encountered in 6% of indomethacin with stent versus 8% in the indomethacin alone group, which translates to a risk difference of 2.1%. Severe pancreatitis was encountered in 1.4% in the indomethacin with stent and 2.1% in the indomethacin alone group. Post-ERCP pancreatitis-related deaths were encountered in 0.3% in the indomethacin alone group. There were no pancreatitis-related deaths in the indomethacin plus stent group. Serious adverse events rates were similar at 36% in both groups. ICU admission was 4% in the indomethacin with stent group and 3% in the indomethacin alone group. The mean hospital stay was 2.9 days in the indomethacin with stent group, with standard deviation of 6.7, and indomethacin alone group, the mean was 3.2 with standard deviation of 7.2 days. The limitation of this study is that there is potential for unmasking, mostly through radiographic tests obtained within 48 hours after ERCP, because you're able to visualize these pancreatic stents on X-ray, which could have influenced care. The endoscopist performing ERCP may have also made procedural decisions with knowledge of the study group assignment, and it is possible that procedural approach could have been altered according to whether or not a stent would be placed. And lastly, all participating centers were tertiary referral centers, which may have affected the generalizability of the study to community endoscopists. So the take-home point is that the strategy of indomethacin alone was not as effective as strategy of indomethacin with prophylactic pancreatic stent placement in the prevention of post-ERCP pancreatitis in high-risk patients. And therefore, these results support the placement of prophylactic pancreatic stents in addition to administration of rectal indomethacin in high-risk patients undergoing ERCP in accordance with current clinical practice guidelines. Our next study was by Yu et al., published in Gastroenterology. This is looking at H. pylori treatment and gastric cancer risk after endoscopic resection of dysplasia. This was a nationwide cohort study. Gastric cancer is currently the 6th leading cause of cancer deaths worldwide, and endoscopic resection is the mainstay of treatment for early gastric cancer because they have a negligible risk of lymph node metastases, but they do have high metachronous recurrence rate of 9.3%. Therefore, efforts have been made to reduce the recurrence of gastric cancer after endoscopic resection, including H. pylori eradication. Persistent H. pylori infection has been reported to be associated with high rates of recurrence after endoscopic resection of cancer, and therefore chemoprevention of H. pylori is recommended to reduce the risk of secondary gastric cancer after endoscopic resection of early gastric cancer. But the evidence supporting H. pylori eradication after endoscopic resection for gastric dysplasia is lacking, with conflicting results. So the aim of this study was to investigate the association between H. pylori therapy and occurrence of gastric cancer after endoscopic resection of gastric intraepithelial neoplasia in a Korean population. This was a retrospective study, a population-based nationwide cohort study looking at health insurance review and assessment database in South Korea, which covers about 97% of the total population. The authors basically searched for patients who received endoscopic resection of gastric intraepithelial neoplasia between 2010 and 2020, and investigators verified the occurrence of new-onset gastric cancer and metachronous gastric neoplasm, which encompasses both cancer and dysplasia more than a year after index endoscopic resection via review of medical records. The primary outcome was the risk of gastric cancer and metachronous gastric neoplasms. So they identified 69,722 patients who underwent endoscopic therapy for dysplasia. And they found that 49% of these patients underwent H. pylori eradication therapy versus 35,000 patients who are untreated. Now, if you look at the duration of follow-up, the overall is 5.6 years, ranging from 3.7 to 7.6 years. The authors then looked at the incidence of gastric cancer, metachronous gastric neoplasm in their identified cohorts, and they found that in the treated population, the incidence rate per 1,000 person years was 5.89 in treated and 6.2 in untreated. For the incidence of metachronous gastric neoplasm, in the treated, the incidence rate per 1,000 person years was 7.2 versus 9.2 in the untreated group. They then performed a Cox regression analysis for development of gastric cancer and gastric neoplasm in that they identified cohort. And as you can see in the multivariate analysis, the incidence of gastric cancer was significantly associated. The incidence of gastric cancer was inversely I'll reword it. So in patients who underwent H. pylori treatment, it was negatively associated with the incidence of gastric cancer with adjusted hazard ratio of 0.88 and p-value of 0.004. Again, the treatment for H. pylori was also negatively associated with metachronous gastric neoplasm with adjusted hazard ratio of 0.76 and p-value of less than 0.001. Then looked at time-varying Cox regression analysis to look at late onset gastric cancer. And as you can see, the incidence was significantly lower in the treated group for both gastric cancer occurring after 3 years and after 5 years with adjusted hazard ratio of 0.84 and 0.80 respectively. The limitation of this study is that it's a retrospective study using claims-based database. The information on H. pylori status after endoscopic resection was not accessible, as the database that they used does not contain data on results of H. pylori detection tests. Rather, they look at patients who were treated and untreated, which means that the untreated group probably included patients who were both H. pylori negative and H. pylori positive. There is no information on the success of re-eradication therapy because there was no code to verify the information in the claims database. And this is also set in a single country, and therefore this may limit generalizability. So in this study, H. pylori therapy after endoscopic resection of gastric dysplasia was associated with a reduced risk of gastric cancer and a metachronous gastric neoplasm occurrence. So to recap this month's Journal Club, strategy of indomethacin alone was not as effective as strategy of indomethacin with prophylactic pancreatic stent placement in the prevention of post-ERCP pancreatitis in high-risk patients. And these results support placement of prophylactic pancreatic stent in addition to rectal indomethacin administration in high-risk patients in accordance with clinical practice guidelines. Also in this nationwide study, H. pylori therapy after endoscopic resection of gastric dysplasia was associated with a reduced risk of gastric cancer and metachronous gastric neoplasm occurrence. Thank you so much for joining us this month for the Orlando GI Journal Club. Our next Journal Club is March 6th, 2024. Thank you so much. Have a wonderful month. Bye.